All right. Hey guys, so this is going to be the pre-recorded lab review for Lab 2, Meninges and Blood Supply for your neuroscience course. So let's go ahead and jump into really quick, just a mission statement for Scrubs. So Scrubs, again, is the student collaborative resources for understanding and Brody success. And this is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. So Scrub members participate in a variety of subcommittees working to create resources for students, by students, and these resources are aiming to offer a unique perspective from students that have walked in your shoes, that have gone through the course, and are now developing resources that we wish we had been exposed to while we were in the course ourselves. So the hope is that this organization will become a staple of the Brodit student body, mostly because we have a great community of collaboration, and I'd like to progress this into the future. So if this mission aligns with any of your goals, and you have a desire to help those behind you, we would love to have you as a member of the team. So disclaimer, these resources are made by students and not faculty. So as such, there is a possibility for errors, although we do vet these resources, so that should mitigate that. If there is a contradiction at any point with your coursework and these videos, please go by your course documents. Again, this is a supplemental resource and it is not a replacement, so these lab reviews will not be a replacement for your lab course pack material or participating in the labs themselves. All right, so now going over some osteology for this particular lab, as it's going to be relevant, we're going to talk about the foramen magnum. So just drawing that back for a second, this is going to be where your spinal cord is entering your cranium. You have your occipital bone posteriorly. What I want to point out is anteriorly is the clonoid processes. You have two anterior clonoid processes and two posterior clonoid processes. In the middle, you have this space. This is going to be the sella turcica. This is where your pituitary gland is going to sit. Okay, so anterior clonoids and posterior clonoids, and we'll talk about why those are important for your meningeal attachments in just a moment. Up in the anterior region of the skull, we want to point out the crista galli and the frontal crest. Okay, so crista galli, and up more anteriorly is going to be your frontal crest. That's part of your frontal bone. Then now going posteriorly, I want to point out this bump. So this bump in the posterior region of the skull in the occipital bone is going to be your internal occipital protuberance. Okay, the internal occipital protuberance is in the posterior portion of the occipital bone. You have an external occipital protuberance, which is going to be seen from a superficial view. So this is going to be internal, inside your cranium. Now, I also want to point out there is a difference between the internal occipital protuberance, which is what we just showed, and the internal occipital crest. So the internal occipital crest is going to be right here. So what I'm highlighting now is the internal occipital crest. This is going to be inferior to the internal occipital protuberance. This is going to be important for dural venous sinuses, which we'll discuss in just a moment. I want to point out the petrous ridge right here. This is the petrous ridge of your temporal bone. Again, the reason that we're pointing out all of these bony landmarks is it is going to be important for the attachment of the dura, and it will also help be regions that we can associate with the dural venous sinuses, which again will go into more detail as this video progresses. The jugular foramen, right down here at the bottom, it's important to remember the cranial nerves that pass through the jugular foramen. So this is going to be cranial nerves 9, 10, and 11. And it's also important to just note that cranial nerves 9, 10, 11 pass through the jugular foramen, but all of your CSF that is draining from the cranium into circulation is going to be passing into the jugular foramen as well. We'll talk about that more in just a moment. Now, we mentioned the sella turcica. I want to mention the clivus once again. The clivus is this anterior region of the skull. Right, and it's, again, really important because you're going to have vasculature that's running on top of it, as well as this is where your brainstem is going to sit as it's entering into the cranium. So if you have a you break this bone and it's dislocated posteriorly into the spinal cord, that can cause some pretty significant defects. Now, we are going to have to go back to our anatomy days for just a moment and remember our foramen in this anterior region of the skull. So let's remember our foramen spinosum, ovale, and lacerum. And how I like to do this is I like to remember them from lateral to medial, spinosum, ovale, lacerum as SOL. So foramen spinosum, foramen ovale, and foramen lacerum. And the way that I remember this is because if I don't remember these foramen, then I am SOL. I am shit out of luck. So spinosum, ovale, lacerum. Okay, so now going into the actual dura itself, You can see that the dura here is still covering the brain tissue, but I want to point out that the dura in the brain, or in the cranium, is going to have two layers, a periosteal layer and a meningeal layer. The periosteal layer is touching the bone. Underneath the periosteal layer, you're going to have a meningeal layer, which is touching the meninges of the brain. So in between those two layers, you have the possibility of forming a sinus, or a dural venous sinus. And this is going to allow, it's pretty much a vein, but instead of the tissue being of a blood tissues, epithelial tissues, or anything of that nature, you're going to have the tissue is going to be made of dura, but it's two layers kind of sandwiched together, and that is a periosteal and meningeal layer. Now, I want to point out on either side of your superior sagittal sinus here, which we'll cover in a little bit more detail, you have these bumps. And you can see one really well there. There's another one down here, one over here. These bumps are your arachnoid granulations. And we'll talk about the pathway of CSF out of the internal regions of the brain in a moment. But what's important to note is that in order for you to drain cerebrospinal fluid, it has to go up through your arachnoid granulations into your dural venous lacunae, which are these widening areas of the dura. That is allowing CSF to drain through the arachnoid granulations into the lacunae, which will then go into these superior sagittal sinus. So these can be damaged in meningitis, for instance, and when they become scarred over due to that, then it can cause some pretty significant defects, and we're going to talk about hydrocephaly, or you will in the class at a later point. And then I want to point out the arachnoid foveolae. These are going to be the impressions of the arachnoid granulations on the skull. So the arachnoid granulations are the protuberances on the dura, but the impression that they leave on the skull are going to be the arachnoid foveolae. Okay, now going into some of the layers of the dura that you learned about in anatomy, so we're going to hit this relatively brief, but let's start with the falx cerebri. So when you see the term falx, be thinking a top to bottom cut. So the falx is oriented superior to inferiorly, and it comes across and it separates your two cerebral hemispheres. So that's why it gets cerebri. So falx cerebri, located right here. That's that invagination of the dura. Okay, you also have a falx cerebelli, which I can't show in this image, but it's going to be underneath this dural layer here. It is partially splitting the cerebellum. Okay, and it's going to be splitting the cerebellum to form the cerebral incisor, which is not a full split like your cerebral hemispheres. Okay, but it is an impression, so that's going to be the falx cerebri. And again, that's going to be below this region, which we can't quite see. Now, forming a kind of a U shape, the tentorium cerebelli. The tentorium cerebelli comes around the sides. The tentorium cerebelli is important because it is going to separate your cerebrum from your cerebellum, which is going to sit underneath the tentorium. Now, you see that there is an open space, right, because your brain tissue still has to be able to get through, so it can't just be covered all over the place. This is your tentorial notch. Okay, so your tentorial notch is located right here. It's this big open space. And then anteriorly, you're going to have the diaphragm ocella. So the diaphragm ocella is going to sit right here. Okay, and the diaphragm ocella is sitting, the attachment points are your anterior and posterior clonoids. So it's sitting around your anterior and posterior clonoids, and it's going to sit right around your pituitary gland. So that's happening more anteriorly. Now, going into some of the bony attachments for these, which is going to be important, as you'll get questions sometimes on the bone, or it could be the dura, and it could be asking about your attachment points. So let's start with the falx cerebri. So the falx cerebri attaches anteriorly at the crista galli and the frontal crest of the frontal bone. So here's your frontal bone. The frontal crest is kind of seen there, and then you can see the crista galli, which is part of your ethmoid bone. If we go posteriorly, the falx cerebri is going to attach at the internal occipital protuberance, which we saw on the skull. Okay, so those are the two attachment points that you need to know for the falx cerebri. The tentorium cerebelli is going to attach on the temporal portions, or the transverse portions of your occipital bone as it's coming around. And as it comes up more anterior and laterally, it's going to attach to the petrous portion of your temporal bone, which is right here. And then it's going to go most anteriorly to attach to the posterior clonoid process. Okay, so your attachment points again are transversely across the occipital bone, then the petrous portion of the temporal bone, and then it's going to go as anteriorly as it can to attach to the posterior clonoid processes. The falx cerebri, which we can't see, right? Falx cerebelli, which we can't see because it's deep to the tentorium, would attach to the cerebral. It's going to form a invagination in the cerebellum, which is going to be called the cerebral incisor. But attachment point is the internal occipital crest, which we saw once again on the skull. And then we mentioned the diaphragm ocella is attaching to your anterior and posterior clonoid processes. Okay, so this is a cartoon image. We'll get into some actual cadaveric images in a second, but I just want to point out the dural venous sinuses, kind of in a cartoon, and then we'll see what they look like in the brain. So the superior sagittal sinus is located on the superior portion of your falx cerebri. So superior sagittal sinus coming around. Let's follow the superior sagittal sinus down, and it's going to drain in to a bifurcation point. This bifurcation point is called the confluence of sinuses. This is where all of your sinuses come together in the occipital region. So superior sagittal sinus going into the confluence of sinuses. The confluence of sinuses then drains laterally on either side, transversely across the occipital bone, and this is your transverse sinus. So this is where your tentorium cerebelli was attaching to the occipital bone. It's happening right at this point. So transverse sinus coming around. Your transverse sinus is eventually going to drain into the sigmoid sinus, which will eventually drain into your internal jugular vein. So these are some of the major sinuses. There are going to be some more that we'll talk about as we move forward. I also want to point out, it's not labeled in this image, but this is your occipital sinus right down here. Okay, occipital sinus. This is formed by your falx cerebelli. Okay, and then I'll point this out, which we'll cover a little bit more in deep depth later, but here is your straight sinus, which drains posteriorly into the confluence of sinuses, and your straight sinus is made up of the inferior sagittal sinus, which is on the inferior portion of your falx cerebri, and the great vein of Galen, which we'll talk about later. But there goes your straight sinus. I do want to point out that your lab course pack makes a point of saying that your superior sagittal sinus will typically drain into the confluence of sinuses, but then the drainage will flow to the right. Okay, the drainage flowing to the right. Whereas the straight sinus typically drains posteriorly, and the drainage then flows to the left. Okay, and make sure that I'm checking myself real quick. Superior sagittal sinus usually flows to the right. Okay, just wanted to make sure that I wasn't telling y'all incorrectly. And you can kind of see that in this image. The straight sinus is coming back and it's inserting a little bit to the left of the superior sagittal sinus. So it makes sense that blood flow, or that CSF flow, would flow to the left, whereas the superior sagittal sinus would flow to the right. Okay, now going into what this actually looks like where the dura is, the superior sagittal sinus will be located at the top of the falx cerebri, coming back to the confluence of sinuses posteriorly. Inferior sagittal sinus is located at the bottom of your falx cerebri. Okay, so here it would end and it would turn into the straight sinus as it drains backwards into your confluence. Let's hit your transverse sinus, would be coming transversely around that occipital bone. Then you'd go anteriorly, you'd have the sigmoid sinus, which we can kind of see it would come down in this region into your jugular vein. Okay, that internal jugular vein is going to be where all of this flow, or these dural venous sinuses are flowing. Now, I do want you to point out, remember your cavernous sinuses from anatomy. They're located kind of deep to this arrow. Okay, your cavernous sinuses, you're going to have one on either side. You can see your trigeminal nerve going into the cavernous sinus area. But what I want to point out is that in between these two, there is a connection that goes through the diaphragm ocella, and that's going to be your intercavernous sinus. So cavernous sinus on either side, and in between you're going to have an intercavernous sinus. All right, now from there we've talked mostly about the dura, we've talked about the different meninges, we've talked about a lot of the dural venous sinuses. We're going to move in just a second into the arterial supply. So I'm going to start most externally, and let's talk about the middle meningeal artery. The middle meningeal artery is located right here, and you can see its branches. But this is supplying the major blood flow to the meninges. Okay, this is a artery So if you you damage this artery, that's going to be a lot of blood. It's a lot different and under a lot higher pressure than your dural venous sinuses. So very important that you know that this middle meningeal artery can be damaged when you damage the arterion, which is the region where the bones fuse together at your temples. So if you hit the side of your head and damage your arterion, you could cause damage to your middle meningeal artery, which will cause an epidural bleed. Right. Now I also want to point out the superior sagittal sinus. Right, superior sagittal sinus coming down, running towards your confluence of sinuses. And again, we have our arachnoid granulations coming up to drain CSF into that superior sagittal sinus. Now going over some of the more internal drainage of the brain, especially with that venous drainage, let's look at this diagram real quick. So just following the superior sagittal sinus around to give us a landmark, and we find the confluence of sinuses. Now, I want to show you that coming up anteriorly, you have a straight sinus. So there is a straight sinus highlighted there. The straight sinus is going to bifurcate into the inferior sagittal sinus, which we saw at the bottom of the falx cerebri. And then it's going to continue anteriorly. This region right here that's highlighted before it bifurcates again is called the great vein of Galen. Great vein of Galen right above the pointer. Now, the great vein of Galen isn't going to bifurcate again. It's going to bifurcate into these basilar veins, which are kind of purple here, and then it's going to bifurcate into these internal cerebral veins, which we see here. These internal cerebral veins are running roughly in association with your fornix in this region, but here's your internal cerebral veins. Now, your internal cerebral veins are going to go anteriorly, and then they're going to do some more bifurcation. So what's going to happen is your internal cerebral veins are going to run anteriorly, and then they're going to loop through the foramen of Monroe, so that way they can get into the lateral ventricle, and you're going to have three branches that you're going to be responsible for knowing. One is the septal branch, which is going to go inside of the septum pellucidum on either side. We'll see that in a cross-section in just a moment. The choroidal veins, which you guessed it, are going to be associated with the choroid plexus, and the thylamostriate vein, which we'll talk about a little bit later, but that's kind of what's being shown here. So it's making this little loop around. Right, so that's that in a diagram, but we're going to see this on some cadaveric specimens moving forward. So I mentioned that we were going to see it on some cadaveric specimens, but let's get our landmarks down first. So what I want to point out is down here you have the pons. Right here you would have the anterior commissure, and then here's your optic chiasm. So this is helping me to locate that this is the anterior side of this image. Superior, inferior. Also, they help back here, you have the pineal gland. So the pineal gland will help me locate that this is the posterior region. Now, this space behind the pineal gland and tectum, before you get down to the cerebellum, this is a cistern. And we'll talk about cisterns in lab 3. But cisterns back here, near the superior part of the brain, this is going to be called the superior cistern. So the space that I'm highlighting here is the superior cistern. That is where your pineal gland is projecting posteriorly. The reason I point this out is because if you see a vein back here in the superior cistern, then by definition, this is your great vein of Galen. So this is the great vein of Galen that we see here. As we run more anteriorly above the thalamus, we are now seeing the internal cerebral veins. Internal cerebral veins here. Eventually they would run anteriorly to get into the foramen of Monroe. Right, and I know this specimen looks a little bit different than the ones you might have seen in lab. This has been dissected out to see some more of the hypothalamic structures, which we'll get to later in the course. So don't worry too much about this dissection down here. This image is just pointing out the great vein of Galen, internal cerebral veins, eventually running into the foramen of Monroe. All right, now we see it in a coronal cross-section, and I would be ready for a test question here. This is something that's pretty common. First, let's point out the septal veins. So the first thing I look for when I'm looking on these cross-sections, I like to find the corpus callosum, which is going right across, connecting the two hemispheres. It's a really surefire structure that you can identify almost always. Running inferiorly from the corpus callosum, we've got the septum pellucidum. So the septum pellucidum, and down inferiorly, it would connect to the fornix. But septum pellucidum, so if you see a lumen, or a little opening space, on either side of the septum, these are going to be the septal veins. So I've got one highlighted here. So septal vein on either side. If I look laterally, this is going to be the head of your caudate nucleus. That's what this gray matter area is. Okay, this little gray matter tract right there is your lenticular striate region, which you won't be responsible for knowing right at this moment. But what you will be responsible for is knowing that beside the caudate nucleus and sitting above the thalamus, which is right in this region, we're a little bit too anterior to be really in the thalamus, but we're going to let it slide for now. Right here, you're going to have your thalamostriate vein. So thalamostriate vein right here where this lumen is located. Right, so pointing this out one more time. Septal veins on either side of the septum pellucidum, thalamostriate vein, located right here between the head of the caudate nucleus and your thalamus. So right there, thalamostriate vein. This is a very high yield one to know, this cross-section image, that beside your caudate nucleus, you've got the thalamostriate vein. All right, so now going into some arterial supplies. This is one that you should know pretty well from anatomy. We're going to go in a little bit more detail than we did then, but this is your basilar system and your circle of Willis. So let's start inferiorly. We've got two vertebral arteries that come from give me a second. It comes off your heart, right? Going anteriorly, you've got your vertebral arteries. They're coming up. Then you come more superiorly, and you've got your basilar artery. The basilar artery is usually one of my main landmarks if I'm looking for arterial supply because it's nice and big. So once I find the basilar and the vertebral arteries, I'll start looking for the pica and the ACA. So your posterior inferior cerebellar artery and anterior inferior cerebellar artery. Your posterior inferior cerebellar artery, the pica, will usually come off of the vertebral arteries. Now, this isn't 100% of the case, but usually you can find it coming off of the vertebral arteries going laterally towards the cerebellum. So this is your pica here. If I follow my basilar artery superiorly, then I can likely find my ACA, my anterior inferior cerebellar artery, coming to supply the cerebellum. Now you say, Ryan, I also see some vessels coming off the vertebral arteries running down. How do I know that that is not the pica? Well, I say, okay, you do have vessels running down anteriorly, and because this is running anteriorly on what will be your spinal cord, we're going to call this the anterior spinal artery. You have one anterior spinal artery, and you're going to have two posterior spinal arteries, which will be coming off kind of out of view here in this image, but they would also be coming off the vertebral artery. Now, as I move anterior or superiorly, there would be some small branches that have been removed here, but those would be pontine branches. So small branches coming off the basilar going to the pons. I continue going superiorly. The next vessel that I see coming off is going to be my superior cerebellar artery. So this vessel I'm highlighting here is my superior cerebellar artery. One way that I can verify that this is my superior cerebellar artery is I have a nerve coming out superior to it. So the vessel that comes out right beneath cranial nerve 3, which is this nerve here, is my superior cerebellar artery. The nerve that comes off more superiorly in this image to my cranial nerve, that is, and this would be more rostral in anatomical position, this would be your posterior cerebral artery. So posterior cerebral artery is more anterior located, and then your posterior cerebellar artery would be more posterior located in anatomical position. Superior cerebellar artery, right there. Now, I want to point out as we're going anteriorly, here is your internal carotid artery, and we see that it has some branches. So this branch here that is going back and connecting to your posterior cerebral artery will be your posterior communicating artery. So posterior communicating there. All right. Now, as we continue laterally, we're going to form the middle cerebral artery. The middle cerebral artery is going through to supply the lateral portions of the brain. Now, I do want to point out, your course pack makes it clear, your MCA is not a part of the circle of Willis. So the MCA is not a part of the circle of Willis. Now, something that is a part of the circle of Willis is your anterior cerebral artery, which we see here, ACA. It's going to be running anteriorly. So ACA coming off of the internal carotid. Now, you see that there's a small artery that connects the ACA on the right and the ACA on the left. So this is going to be your anterior communicating artery. Okay, anterior communicating artery. Now, if you look real close, you might see that there's another vessel coming off of your anterior cerebral artery coming backwards. You'd be like, what is going on there? And that artery is not only coming backwards, it's kind of coming to the region beneath your optic tract olfactory tract, where it bifurcates, and coming right below it, so that vessel coming back, that is going to be the recurrent artery of Hübner. So I want to point out the recurrent artery of Hübner comes off roughly in the same region as your anterior communicating artery, but it is going to be backtracking and going to the regions below the olfactory tract, because this is going to be giving off small branches that are going to form the anterior perforating substance, which we know is located right in this region. All right, and with that, some other branches that you would see coming off of the internal carotid, although they're a little bit hard to identify from this image, would be your ophthalmic artery and your anterior choroidal artery. All right, so now looking from a mid-sagittal view of the brain, I want to point out that your anterior cerebral artery is doing most of the midline structures of the brain. So the anterior cerebral artery is actually right here, and it was cut, but the anterior cerebral artery bifurcates as it goes distally. So it bifurcates into a vessel that goes right on top of the corpus callosum, and that colossal sulcus, that would be your pericolossal artery. So the pericolossal artery goes in the colossal sulcus. Now, you also have a colossomarginal artery. That is the one that comes a little bit more superiorly, and that is going to be in your marginal sulcus. Okay, so you've got your colossomarginal artery and your pericolossal arteries. These are both continuations of your anterior cerebral artery going up and supplying your midline structures. Now, I want to point out that you can see these same vessels from a coronal cross-section. Now, you can't quite see the lumens because we're zoomed out so much, but I'm going to point out where you should expect to see them. So, we said the pericolossal artery is right over top or superior to the corpus callosum, underneath the cingulate gyrus. So we would expect to see those vessels right where the pointer is now. And we can see that on both sides. So the vessel that runs, if you see a zoomed in image, and you're above the corpus callosum, but below the cingulate gyrus, that would be your pericolossal artery. Now, if I were to go more superiorly into the marginal sulcus, then I would see this would be the colossomarginal artery up here more superiorly. Okay, so colossomarginal artery located more superiorly, pericolossal artery located more inferiorly, right above the corpus callosum. Now, I want to end this video with talking about some of the clinical correlations that were mentioned in the course pack. So let's start with the lenticulostriate stroke. So the lenticulostriate arteries are branches primarily off of your middle cerebral artery, and they supply the deep regions of the brain, so your basal ganglia and so the deep gray matter regions. Now, if you have a hemorrhagic stroke, then you could end up with this particular presentation here. So you see that there's a lot of blood that has been formed right in the deep structures of the brain. So this is really just going to highlight the lenticulostriate region, or vessels are going to supply deep brain regions. Okay, you can also have an ischemic stroke, which means that there was a blockage of blood flow and the tissue died posteriorly or distal to that. But in this case, this is representing a hemorrhagic stroke, meaning there was blood that was bleeding out into the brain tissue. Now, something that wouldn't be really this dramatic, but an arteriovenous malformation, this is when you have an artery and a vein connected to one another with no capillary in between. So this is a developmental issue where your capillary beds don't develop correctly. But what this can happen is you have an artery, which is under high pressure, draining directly into a vein, which is low pressure. And what it can cause is the veins to blow out or get really big. So that's what we're seeing in this bottom image. So you're seeing a massive arteriovenous malformation up here in this region of the brain. Now, typically, you wouldn't see this present in such a significant way, but I just want to point that out because it is within your course pack. Next thing I want to point out is the difference between the epidural, subdural, and subarachnoid hemorrhages. So an epidural hemorrhage is happening above the periosteal layer of the dura, and this is going to happen specifically with damage to the middle meningeal artery. Okay, so this is going to be arterial blood. So you can imagine with arterial blood, you're going to get a faster bleed than if this was venous blood. So middle meningeal artery damage, and it's going to cause this pushed-in lesion, this lens shape of arterial blood pushing in on the dura. Now, if you had tearing of your bridging veins, or you had a tear of your superior sagittal sinus, which is located right here, then you could end up with a subdural hematoma. So subdural hematoma here, and that is going to be venous blood. So it's not going to be quite as severe as a deterioration as you would see with the middle meningeal artery. Now, the most severe hemorrhage that you could have would be a subarachnoid hemorrhage. Now, a subarachnoid hemorrhage is happening below the arachnoid mater, which is your second layer of meninges. Now, the subarachnoid space is where all of your major arteries and arterial blood that supply the brain are located. So that's going to be your circle of Willis and your basilar artery are all located in the subarachnoid space. So if you have a subarachnoid hemorrhage, that's going to be a lot of blood that's being dumped out into some very important structures. So this is quite severe, and it's going to be deteriorating very, very rapidly. And so this is most commonly occurring due to a Berry aneurysm, which means there's a dilation of one of the blood vessels on the circle of Willis, commonly at one of the branch points, and this can cause weakening of the blood vessel, meaning it's more likely to rupture. The last thing I want to point out is a subfalcine hernia. A subfalcine hernia means sub-falx, so below the falx cerebri. So you have herniation below the falx cerebri, and it's specifically herniation of that cingulate region, or it could be some of the midline structures of that specific hemisphere. So what are some of the defects I would expect with a subfalcine hernia? Well, with a subfalcine hernia, like we see here, if this region of the brain was pushing underneath the falx cerebri and getting compressed, then I would expect to have loss, especially if it hit my central lobule, then I would expect to have loss of sensation and movement to the contralateral leg. Okay, and then there would also be some associations with the cingulate gyrus, which you haven't covered in class yet, which will be later in the course. But I do want to point out, if you had a subfalcine hernia, then the most likely thing that you would expect to see motor-wise would be contralateral leg, and that's due to the homunculus having the leg located in the midline, where you get the torso, head, and arms located more laterally. And with that, that'll bring a close to this particular video.